Malaria is a mosquito-borne infectious disease of humans and other animals caused by parasitic protozoans belonging to the genus Plasmodium. Malaria causes symptoms that typically include fever, fatigue, vomiting, and headaches. In severe cases it can cause yellow skin, seizures, coma or death. The disease is transmitted by the biting of mosquitoes, and the symptoms usually begin 10 to 15 days after being bitten. If not properly treated, people may have recurrences of the disease months later. In those who have recently survived an infection, reinfection usually causes milder symptoms. This partial resistance disappears over months to years if the person has no continuing exposure to malaria. The disease is most commonly transmitted by an infected female Anopheles mosquito. The mosquito bite introduces the parasites from the mosquito's saliva into a person's blood. The parasites travel to the liver where they mature and reproduce. 5 species of Plasmodium can infect and be spread by humans. Most deaths are caused by P. falciparum because P. vivax, oval, and P. malariae generally cause a milder form of malaria. The species P. knowlesi rarely causes disease in humans. Malaria is typically diagnosed by the microscopic examination of blood using blood films, or with antigen-based rapid diagnostic tests. Methods that use the polymerase chain reaction to detect the parasite's DNA have been developed, but are not widely used in areas where malaria is common due to their cost and complexity. The risk of disease can be reduced by preventing mosquito bites by using mosquito nets and insect repellents, or with mosquito control measures such as spraying insecticides and draining standing water. Several medications are available to prevent malaria in travelers to areas where the disease is common. Occasional doses of the medication sulfadoxine, pyrimethamine are recommended in infants and after the first trimester of pregnancy in areas with high rates of malaria. Despite a need, no effective vaccine exists, although efforts to develop one are ongoing. The recommended treatment for malaria is a combination of antimalarial medications that includes an artemisinin. The second medication may be either mefloquine, lumefantrine, or sulfadoxine, pyrimethamine. Quinine along with doxycycline may be used if an artemisinin is not available. It is recommended that in areas where the disease is common, malaria is confirmed if possible before treatment is started due to concerns of increasing drug resistance. Resistance among the parasites has developed to several antimalarial medications. For example, chloroquine-resistant P. falciparum has spread to most malarial areas, and resistance to artemisinin has become a problem in some parts of Southeast Asia. The disease is widespread in the tropical and subtropical regions that exist in a broad band around the equator. This includes much of sub-Saharan Africa, Asia, and Latin America. Malaria is commonly associated with poverty and has a major negative effect on economic development. In Africa, it is estimated to result in losses of $12 billion a year due to increased healthcare costs, lost ability to work, and negative effects on tourism. The World Health Organization reports there were 198 million cases of malaria worldwide in 2013. This resulted in an estimated 584,000 to 855,000 deaths, the majority of which occurred in Africa. Signs and symptoms. The signs and symptoms of malaria typically began 8 to 25 days following infection. However, symptoms may occur later in those who have taken antimalarial medications as prevention. Initial manifestations of the disease, common to all malaria species, are similar to flu-like symptoms, and can resemble other conditions such as sepsis, gastroenteritis, and viral diseases. The presentation may include headache, fever, shivering, joint pain, vomiting, hemolytic anemia, jaundice, hemoglobin in the urine, retinal damage, and convulsions. The classic symptom of malaria is paroxysm, a cyclical occurrence of sudden coldness followed by shivering and then fever and sweating, occurring every 2 days in P. vivax and P. oval infections, and every 3 days for P. malariae. P. falciparum infection can cause recurrent fever every 36 to 48 hours, or a less pronounced and almost continuous fever. Severe malaria is usually caused by P. falciparum. Symptoms of falciparum malaria arise 9 to 30 days after infection. Individuals with cerebral malaria frequently exhibit neurological symptoms, including abnormal posturing, nystagmus, conjugate gaze palsy, opisthotonus, seizures, or coma. Complications. Malaria has several serious complications. Among these is the development of respiratory distress, which occurs in up to 25% of adults and 40% of children with severe P. falciparum malaria. Possible causes include respiratory compensation of metabolic acidosis, non-cardiogenic pulmonary edema, concomitant pneumonia, and severe anemia. Although rare in young children with severe malaria, acute respiratory distress syndrome occurs in 5 to 25% of adults and up to 29% of pregnant women. Co-infection of HIV with malaria increases mortality. Renal failure is a feature of blackwater fever, where hemoglobin from lysyl red blood cells leaks into the urine. Infection with P. falciparum may result in cerebral malaria, a form of severe malaria that involves encephalopathy. It is associated with retinal whitening, which may be a useful clinical sign in distinguishing malaria from other causes of fever. Splenomegaly, severe headache, hepatomegaly, hypoglycemia, and hemoglobinuria with renal failure may occur. Complications may include spontaneous bleeding and coagulopathy. May cause shock. Malaria in pregnant women is an important cause of stillbirths, infant mortality, abortion and low birth weight, particularly in P. falciparum infection, but also with P. vivax. Cause. Malaria parasites belong to the genus Plasmodium. In humans, malaria is caused by P. falciparum, malariae, oval, vivax and P. knowlesi. Among those infected, Falciparum is the most common species identified, followed by P. vivax. Although P. falciparum traditionally accounts for the majority of deaths, recent evidence suggests that P. vivax malaria is associated with potentially life-threatening conditions about as often as with a diagnosis of P. falciparum infection. P. vivax proportionally is more common outside Africa. There have been documented human infections with several species of Plasmodium from higher apes. However, except for P. knowlesi, a zoonotic species that causes malaria in macaques, these are mostly of limited public health importance. Global warming is likely to affect malaria transmission, but the severity and geographic distribution of such effects is uncertain. Life cycle. In the life cycle of Plasmodium, a female Anopheles mosquito transmits a motile infective form to a vertebrate host such as a human, thus acting as a transmission vector. A sporozoa travels through the blood vessels to liver cells, where it reproduces asexually, producing thousands of merozoites. These infect new red blood cells and initiate a series of asexual multiplication cycles that produce 8 to 24 new infective merozoites, at which point the cells burst and the infective cycle begins anew. Other merozoites develop into immature gametocytes, which are the precursors of male and female gametes. When a fertilized mosquito bites an infected person, gametocytes are taken up with the blood and mature in the mosquito gut. The male and female gametocytes fuse and form an ookineta, a fertilized, motile zygote. Ookinetes develop into new sporozoites that migrate to the insect's salivary glands, ready to infect a new vertebrate host. The sporozoites are injected into the skin, in the saliva, when the mosquito takes a subsequent blood meal. Only female mosquitoes feed on blood, male mosquitoes feed on plant nectar, and do not transmit the disease. The females of the Anopheles genus of mosquito prefer to feed at night. They usually start searching for a meal at dusk, and will continue throughout the night until taking a meal. Malaria parasites can also be transmitted by blood transfusions, although this is rare. Recurrent malaria. Symptoms of malaria can recur after varying symptom-free periods. Depending upon the cause, recurrence can be classified as either recrudescence, relapse, or reinfection. Recrudescence is when symptoms return after a symptom-free period. It is caused by parasites surviving in the blood as a result of inadequate or ineffective treatment. Relapse is when symptoms reappear after the parasites have been eliminated from blood but persist as dormant hypnozoites in liver cells. Relapse commonly occurs between 8 to 24 weeks and is commonly seen with P. vivax and P. aval infections. P. vivax malaria cases in temperate areas often involve overwintering by hypnozoites, with relapses beginning the year after the mosquito bite. Reinfection means the parasite that caused the past infection was eliminated from the body but a new parasite was introduced. Reinfection cannot readily be distinguished from recrudescence. Although recurrence of infection within 2 weeks of treatment for the initial infection is typically attributed to treatment failure, people may develop some immunity when exposed to frequent infections. Pathophysiology. Malaria infection develops via 2 phases. One that involves the liver, and one that involves red blood cells, or erythrocytes. When an infected mosquito pierces a person's skin to take a blood meal, sporozoites in the mosquito's saliva enter the bloodstream and migrate to the liver where they infect hepatocytes, multiplying asexually and asymptomatically for a period of 8 to 30 days. After a potential dormant period in the liver, these organisms differentiate to yield thousands of merozoites, which, following rupture of their host cells, escape into the blood and infect red blood cells to begin the erythrocytic stage of the life cycle. The parasite escapes from the liver undetected by wrapping itself in the cell membrane of the infected host liver cell. Within the red blood cells, the parasites multiply further, again asexually, periodically breaking out of their host cells to invade fresh red blood cells. Several such amplification cycles occur. Thus, classical descriptions of waves of fever arise from simultaneous waves of merozoites escaping and infecting red blood cells. Some P. vivax sporozoites do not immediately develop into exoerythrocytic phase merozoites, but instead produce hypnozoites that remain dormant for periods ranging from several months to several years. After a period of dormancy, they reactivate and produce merozoites. Hypnozoites are responsible for long incubation and late relapses in P. vivax infections, although their existence in P. aval is uncertain. The parasite is relatively protected from attack by the body's immune system because for most of its human life cycle it resides within the liver and blood cells and is relatively invisible to immune surveillance. However, circulating infected blood cells are destroyed in the spleen. To avoid this fate, the P. Falciparum parasite displays adhesive proteins on the surface of the infected blood cells, causing the blood cells to stick to the walls of small blood vessels, thereby sequestering the parasite from passage through the general circulation and the spleen. The blockage of the microvasculature causes symptoms such as in placental malaria. Sequestered red blood cells can breach the blood-brain barrier and cause cerebral malaria. Genetic resistance. According to a 2005 review, due to the high levels of mortality and morbidity caused by malaria, especially the P. Falciparum species, it has placed the greatest selective pressure on the human genome in recent history. Several genetic factors provide some resistance to it, including sickle cell trait, thalassemia traits, glucose 6-phosphate dehydrogenase deficiency, and the absence of Duffy antigens on red blood cells. The impact of sickle cell trait on malaria immunity illustrates some evolutionary trade-offs that have occurred because of endemic malaria. Sickle cell trait causes a change in the hemoglobin molecule in the blood. Normally, red blood cells have a very flexible, biconcave shape that allows them to move through narrow capillaries. However, when the modified hemoglobin S molecules are exposed to low amounts of oxygen, or crowd together due to dehydration, they can stick together to forming strands that cause the cell to sickle or distort into a curved shape. In these strands, the molecule is not as effective in taking or releasing oxygen, and the cell is not flexible enough to circulate freely. In the early stages of malaria, the parasite can cause infected red cells to sickle, and so they are removed from circulation sooner. This reduces the frequency with which malaria parasites complete their life cycle in the cell. Individuals who are homozygous have sickle cell anemia, while those who are heterozygous experience resistance to malaria without severe anemia. Although the shorter life expectancy for those with the homozygous condition would tend to disfavor the trait's survival, the trait is preserved in malaria-prone regions because of the benefits provided by the heterozygous form. Liver dysfunction as a result of malaria is uncommon and usually only occurs in those with other liver conditions such as viral hepatitis or chronic liver disease. The syndrome is sometimes called malarial hepatitis. While it has been considered a rare occurrence, malarial hepatopathy has seen an increase, particularly in Southeast Asia and India. Liver compromise in people with malaria correlates with a greater likelihood of complications and death. Diagnosis. Owing to the non-specific nature of the presentation of symptoms, diagnosis of malaria in non-endemic areas requires a high degree of suspicion, which might be elicited by any of the following: recent travel history, enlarged spleen, fever, low number of platelets in the blood, and higher than normal levels of bilirubin in the blood combined with a normal level of white blood cells. Malaria is usually confirmed by the microscopic examination of blood films or by antigen-based rapid diagnostic tests. Microscopy is the most commonly used method to detect the malarial parasite. About 165 million blood films were examined for malaria in 2010. Despite its widespread usage, diagnosis by microscopy suffers from two main drawbacks. Many settings are not equipped to perform the test, and the accuracy of the results depends on both the skill of the person examining the blood film and the levels of the parasite in the blood. The sensitivity of blood films ranges from 75 to 90% in optimum conditions, to as low as 50%. Commercially available RDTs are often more accurate than blood films at predicting the presence of malaria parasites, but they are widely variable in diagnostic sensitivity and specificity depending on manufacturer, and are unable to tell how many parasites are present. In regions where laboratory tests are readily available, malaria should be suspected, and tested for, in any unwell person who has been in an area where malaria is endemic. In areas that cannot afford laboratory diagnostic tests, it has become common to use only a history of fever as the indication to treat for malaria, thus the common teaching, fever equals malaria unless proven otherwise. A drawback of this practice is overdiagnosis of malaria and mismanagement of non-malarial fever, which wastes limited resources, erodes confidence in the healthcare system, and contributes to drug resistance. Although polymerase chain reaction-based tests have been developed, they are not widely used in areas where malaria is common as of 2012, due to their complexity. Classification: malaria is classified into either severe or uncomplicated by the World Health Organization. It is deemed severe when any of the following criteria are present, otherwise it is considered uncomplicated. Decreased consciousness, significant weakness such that the person is unable to walk, inability to feed, 2 or more convulsions, low blood pressure, breathing problems, circulatory shock, kidney failure or hemoglobin in the urine, bleeding problems, or hemoglobin less than 50 grams L, pulmonary edema, blood glucose less than 2.2 mmol L, acidosis or lactate levels of greater than 5 mmol L, a parasite level in the blood of greater than 100,000 per microliter in low-intensity transmission areas, or 250,000 per micro-L in high-intensity transmission areas. Cerebral malaria is defined as a severe P. Falciparum malaria presenting with neurological symptoms, including coma, or with a coma that lasts longer than 30 minutes after a seizure.